Wabarakatuh. Salatu wassalam ala Rasulullah. I would like to thank the organizing committee, Dr. Nizar and his group, for asking me to talk to you today about facing of the unknowns of IDs. As our specialty is always facing the unknowns and what causes of the diseases. Previously, I was going to be talking didactic, but since the symposium, in a way, it is like a cases, so I thought that I would throw some cases, so I changed all my slides over the last 2 days. I was going to talk about clinical ID cases that they are look-alike. They are different situations with resources and time and place that you sometimes have the facilities to do actions regarding investigations and also the time to treat or to see the patient later on, or in the places because of its crowdedness or because of moving people. About the difficulty of making the clinical suspicion and also making sure that we are, as a practitioner, safe and healthy and not infecting our colleagues, and alerting our microbiologist colleagues about our worries and if there is any threat for them to have them in biosafety containment, and informing the appropriate authorities in your local hospital and your local jurisdiction. As you know, there have been many outbreaks happening all around the world, and Saudi Arabia, we have already a few of these diseases like dengue, Rift Valley, Al-Humra, and also we have the H1N1 influenza in 2009, and recently with the novel corona, which I will be talking at the end of my talk about it. And recently the H7N9 to be awaited to arrive in Saudi Arabia. Why it would arrive? قال الله تعالى وأذن في الناس بالحج يأتوك رجالا وعلى كل ضامر يأتين من كل فج عميق. People are coming from different parts of the world, from China to North America, from South America to Europe, and from Africa to India. So all of these diseases are going back and forth around the world, and we are during Umrah and during Hajj are exposed to these kind of dilemmas with these cases. There are crowdness of people who are living. There are many people who are coming from different parts of the world, mixing with different parts of the other people who are not been exposed to previous diseases, and there are so many vectors that could also transmit the infections within the Hajj time. There are good facilities that Ministry of Health has already established for the Hajj. This is the ICUs, and it has been upgraded and are very high standard to deal with very sophisticated and very advanced cases in their ICUs. And they have also established a good laboratories and chains of laboratories. During that time, there are a teamwork that are from different nationals of international physicians, laboratories, and also from the local people who have different backgrounds, are working together to serve these Hajjis and to serve their brothers in the Hajj. They are providing the care, and they are working together to make sure that Hajj pass without any major problems. They all dissolve to serve one aim, and they are yearly coming back, and because it is very privileged to be in Hajj. I have been with many of my colleagues. I learned from them a lot. Some of them, you have listened to them over the last 2 days, and one, Dr. Migbil Hidathi here, Professor Tariq Madani, Dr. Muhammad Al-Hazmi, Dr. Tariq Al-Azraqi. We've been in so many teams over the last years, working together to serve these Hajjis, and I'm privileged to do that, and also learning from them. And Dr. Abdul Hakim Al-Thaqafi, Dr. So the difficulties in Hajj is the weather and the environment and the resources and the attitude and the practice of our brother Hajjis that comes during the Hajj, and they are exposing themselves to be in the open areas with no housing, and also to eat from the international buffet that are provided during the Hajj, and during our brothers also cooking up in the outside and exposing themselves to gastroenteritis and other diseases. On top of that, shaving in the open, and just beside, sharing the razors between the Hajjis, and they are not utilizing the barber shops. We start now with the cases. This is a lady that we saw in 2009. She's a 54-year-old Syrian lady who had complained of fever and dry cheek swelling for 2 days. She has increased with the drinking of acidic juices. She has a brilliant exudate from her internal buccal and it opposite to her molar tooth. So the diagnosis, is this a mump? We were called as an ID physician to see this case as a mump cases. It is not a mump, it is salivary gland infections, most likely bacterial, secondary to a stone that are blocking her duct. And it was a painful lump, and it's usually common in older people, but also in small children. The complication is the severe pain, high fever, and abscess. The bumps is usually describes as those who had bilateral cheek enlargement, and it's usually in 30 to 40% of the bump cases to have this kind of swelling. And it's usually after 2 days of predominance of fever and headache. Other viral, it's influenza, Epstein-Barr virus, CMV, Coxsackie, and HIV. Common things in Hajj also we see is cellulitis and foot injuries. And we could see some cases of foot infections and also sometimes lymphadenitis and cellulitis. I will describe to you a very bad case of a 45-year-old Egyptian driver who is diabetic. He was brought to the ER at 5 a.m. because he is having fever. His colleagues were saying that he's confused and he's agitated. He had a left leg pain that has been for 3 days, but since he's a driver and he's serving in the buses, he wasn't having any time to come to the health facilities. His blood pressure was 97/50, his heart rate was around 100, and he was on NORAD when we saw him in the morning. He was acidotic, and he was hypoxic, and he has leukopenia, and he has low platelet. So the diagnosis? Necrotizing fasciitis caused by? Strep infection. So he's a diabetic, so he's also on top of that, you think about other gram negatives. Unfortunately, within 16 hours, he died. During that time, we were seeing the bullae that are coming on top of each other. We could not move him to a very advanced tertiary center because he was always needing high oxygenation and high nitropes. We tried to convince our surgeon to do the surgery to save his leg by de-articulations of his left thigh, but it was almost late. The culture from the organism that we took from the bullae and from the tissue came to be later on as a gram-negative organisms, and there was no beta hemolytic, so it was not a group A strep. We throw all the antibiotics, immunoglobulins on him, and he was supported fully, but unfortunately, sometimes you can't save patients. There are also some rare cases and sometimes they come in twos. First, from Mauritania, 45-year-old male, well before, he had chronic headache, fever on and off for 4 days after arriving from Medina. He's allergic to paracetamol. I don't know what does that mean, but this is what he told us, and there are language barrier with our colleagues that are coming from different parts of the world. He had left Mauritania 10 days ago. He's febrile and shivering. His CBC was, WBC was 3.7, hemoglobin was 13, platelet was on the lower side. His LFTs was mildly elevated, and his creatinine was, and BUN was 1.1 and 34. He had a malaria film which showed that he had Plasmodium vivax. Is this common in Mauritania? Okay. So we don't have an idea. So we treated him with chloroquine, and we gave him the Primaquine to get the eradication, and he did well afterward. During that night, we have to search for seeing if there is in Mauritania any cases. We saw that yes, Mauritania has cases and usually are in the south. And this is from UK data. We saw the CDC data regarding the types of malaria that are in Mauritania, and it was falciparum in 85%, ovale 5 to 10%, and very rarely to have Vivax. So we have to go back and check the malaria film to make sure that it's not ovale, although the treatment would be the same, but it was Vivax confirmed by 2 other colleagues. So yes, it is rare to get from Mauritania. And this year we had another case with a similar thing, and it coming from Libya. And we have our colleague from Libya, DrAli Albaraak, who was with us, and he consisted say that there is no malaria in Libya except in the south. This guy was from the north. He had also malaria. So there are areas that you could see that have no history of malaria or certain types of malaria, and then at the end you see that they had the rare types of malaria. Sahel Al-Aj, 70 years old male, diabetic, fever on and off for 4 days after arriving from Medina. He had febrile and shivering, the same picture, and his creatinine was a bit elevated, and glucose was 124. So what is the diagnosis? Hemorrhagic fever, malaria, TB, or others. So it is malaria again. And it was Plasmodium falciparum, and it is common also in Sahel Al-Aj. So the treatment of Plasmodium falciparum in Saudis and during the Hajj is to give artiscope for those who are able to take orally, and for those who cannot take, we have to give the artesunate. So may Allah accept their Hajj and continue our work for serving these our brothers. During one of the Hajj times, we were called to see on the 3rd day of Hajj. And during that time, there was a cluster of pneumonia happening in the ICU, and one patient had died. So the suspicion of avian influenza was high, and I will tell you why. And there was a need quick response now while Hajj is ongoing. So somebody had to go from the Hajj to see these kind of clusters and come back again if he's able to come back again. Why we're thinking about avian influenza? Because a few days before that, there was a report from Turkey that there are few cases of avian influenza, and there are people who are coming from the north, coming to Saudi Arabia Hajjis, and they might come with the same problem. So there was an alert, and there was suspicious of what's going on. So on the go, we arrived in the hospital in the evening, and we have met with the concerned hospital personnel. And the goal was of our outbreak is to identify the source of illness and to guide the public health intervention. Dr. Mohammed Halawani and Dr. Mohammed Al-Hazmi yesterday talked to you about how to handle the outbreaks. And the way to recognize that an outbreak is going on is by looking into if there is a routine surveillance activities. And unfortunately, most of our hospitals are deficient with that. And the report from clinical and laboratories asking them about specific questions if they have seen similar cases, and the report from affected individual. And these are the steps of the outbreak investigation: to verify the diagnosis and confirm outbreak, define the cases, make a table of the cases, and take immediate control measure, and formulate and test hypotheses, plan, execute additional studies, and implement and evaluate, and then communicate the findings. So when we arrived there at night, there were 7 cases in the ICU and long-term ventilated unit. 1 mortality had happened already. She was admitted 2 weeks before and transferred from a private hospital. There were 2 cases admitted after her, and there were 4 cases being in the ward in the ICU. Reviewing of the files overnight and meeting the physicians, visited the sites and looking into the files, we found the first case. The first case is the mortality case. This is a young lady, Saudi, who was living in the cities and otherwise healthy according to her family, and there was no previous infections that she had. She visited a farm 3 days before, and before her sickness. She was complaining of cough, shortness of breath for 3 days, 1 day of fever. She was brought to the private hospital after 3 days, and she was very sick at that time. She was unwell, and she was hypotensive, and she was cyanosed, starting to have respiratory failure. She was intubated immediately, iron tubes were started, and cultures were taken from the blood, sputum, everywhere. And she was started on IV meropenem. And this is for Dr. Maha to see if there is a suggestion about stewardship in that private hospital. She was transferred to the ICU. She was transferred to the government hospital within 24 hours, where they take her because she was very sick. She continued, when she arrived to the government hospital, she was continued the same support and antibiotics. They added azithromycin covering for the atypicals. She did not get better, unfortunately. She was needing more oxygenation. They have to increase the beep, and she had ended up with the pneumothorax bilaterally, and she was very, very sick for the next 14 days, and unfortunately, she died. She had no positive cultures in the government hospital, and that was the worrisome. That they were taking blood cultures after the 1 day of being in the private hospital, and all her cultures from admission till the end, it was negative. But looking back to the referring hospital and getting the information from them, what we got is that the blood culture were growing strep pneumo. How common is strep pneumo causing death in a young, healthy adult? It is not common, but it is up to 10% that they might die if, even with appropriate antibiotic that was given to her from day one, and she was in the ER, and we make sure that she was receiving the antibiotic in the ER. She received meropenem, and she continued after. But the cascade of inflammation that comes usually with the strep pneumo, they are very drastic, and unfortunately, this is one of the fatal cases of strep pneumo. What about the other cases? The other cases were elderly, multiple medical problems. 2 cases were complicated surgical patients. And they're not close contact with this patient, the patient who died, and they are located at distance from each other. They had acquired ventilator-associated pneumonia. They have different organisms with Acinetobacter, Pseudomonas, MRSA, but there was no strep pneumo or influenza from these cases. So this is a scenario of a pseudo outbreak that is happening and a false alert. So we have to be always on the alert that we might be called for misguided outbreaks. This is unrelated cases of similar but unrelated diseases. We had reassured the administration of that hospital and the health authorities there. Samples were taken for MOH, and we have to confirm all the time that you take the samples and send it for reference labs. And actions for better infection control to reduce the VAP in the ICU. This outbreak, pseudo-outbreak alert was for 24 hours and sorted out completely. We move on to 2012. This is in Riyadh. This is in our hospital. On the 14th of October, we were called in the ER that there is a teacher who's a smoker, diabetic, post-cabbage 1 year ago, and he had a single kidney. On the 10th of October, he visited our hospital to the ER, and he was labeled as upper respiratory tract infection, and he was sent home. This is his chest X-ray. 2 days later, he came to the ER, and he was very sick, and he was admitted as probably a community-acquired pneumonia with probably an infiltrate on the right lower lobe. He was not getting better, and antibiotics were started. He was given ceftriaxone, azithromycin, and he was started as query also Tamiflu. Unfortunately, on the 13th of October, continued to be hypoxic and continued to be unwell, and they thought that he probably had an influenza, and the dose was doubled for him. And over the last 2 days, we had no cultures that are coming from as bacterial, and we have the influenza for H1N1 and other influenza A and influenza B all came to be negative within 2 days. His renal function get worse. He has a single kidney, and he was labeled as severe acute respiratory infection with renal impairment. So infection control were applied and informed the preventive medicine to call the MOH and the health directorate, because this is one of the cases of definitions of the new novel coronaviruses that we have established 2 weeks before this case. The specimen was sent to the Ministry of Health laboratory for diagnostic, and continue his support for the respiratory anatropes, and renal and steroid were added because he was getting worse, and according to the ICU protocol, they add steroid for him. So what do you think the cause of that, of his illness? On the 23rd of October, while we are in Hajj, we were called that the patient has a novel coronavirus positive from Jeddah at that time, because it was done here. And another specimen, and Dr. Lulwa Al-Abdan was the one who, our fellow, she was the one who took the specimen for the second, because I wasn't in Riyadh, and they sent it to UK to confirm it, and it came to be positive. And we have published this in the Saudi Medical Journal, because this is the first survivor of the coronavirus who had got out of the hospital freely from any complication and freely from any, he walked out home. As of this week, we had only 17 cases worldwide. We have 11 deaths out of them. Jordan have 2. Saudi Arabia, we have 9. 3 of them in my hospital. UK, 4. Germany has 2. And these 2 are coming, the UK and Germany, some of them were coming from the Arabian Peninsula. The existence in other parts of the world cannot be excluded because no other people are checking on them. They are not doing this as routinely. I will line list you the 17 cases and also link them all together. So the first case is the guy who is from Jeddah, who's from Bisha and came to Jeddah. He's a 60-year-old male who had been admitted to a hospital in Jeddah where he had another pathogens, and somebody did the coronavirus did further investigation and got the coronavirus, and this is a case that has been reported here by Dr. Ali Zaki. The second case was the 49-year-old male who was from Qatar, who had been medevaced to UK, and he had on the 3rd of September, and he's been hospitalized on the 7th of September, and he continued to be alive as of last month. And unfortunately, he's still on the ECMO, portable ECMO, because of his lung damage. Our case was the 45-year-old male who was diagnosed on the 10th of October in Saudi Arabia in our hospital, and he is the one well and at home. So these are the three cases when we had our case. Later on, we learned about the other two cases. In April last year, the same month as of this month, in Az-Zarqa in Jordan, there was a cluster of 11 cases of severe pneumonia. There were 7 nurses, 1 physician, and 1 brother of the nurses that had been very sick during that time, and 2 patients. The first patient was a 40-year-old female nurse who had died in April, and 25-year-old male patient who also had died. And the specimen were kept in Az-Zarqa, and later on, when we had in September the announcement, they tested them and it came to be positive. All other cases, or the available cases, were coronavirus. Our case is number 3. The 3 is the Jeddah from Bisha. 4 is our case, and the 5th is Saudi. The 5th is our case, and the 6th is the one from Qatar who has been deported. Who has been medevaced to Germany. During that month of October, we had another 3 cases, and this was a cluster. This is a 70-year-old male, the grandfather, who had comorbidity, who has been admitted to the hospital, and then after that he was admitted with other causes of heart failure, and then after that he had respiratory illness, and he turned to be coronavirus. He died, unfortunately. His son A had his symptoms started on the 28th after his death, 4 days. And then he died within other 4 days. The third case was the 31-year-old male, is the second son of that grandfather, and he also got the coronavirus and he was alive. The son of the son A had the similar illness, but unfortunately his coronavirus is negative. I want to remember this scenario because it's going to be repeating it again later on. So from the 4th of November, we had no cases for 50 days. 50 days worldwide, there was quietness. There was no other cases that has been reported. On the 24th of January this year, we had a Saudi gentleman, female, who was in Egypt from the 10th to the 18th of January. She became sick on the 24th of January, and she had died on the 10th of February. Later on, in UK, we had another clusters of families. We start with the male who was originally from Pakistan, who had visited Pakistan and stayed for 1 month, and then passed through Saudi Arabia, did Umrah, and went with his daughter to UK. He became sick on the 26th of January, and he died on the 19th of March with respiratory illness, and he was positive. His son, who was 38-year-old male, had a cancer, and he was on chemotherapy. He got sick on the 6th of February, and he died on the 17th of February. A distant family member, female, who had visited the gentleman for three times, and she has been recovered from the coronavirus. So we are now reaching to the 13th case. The 14th case is a 69-year-old male who had also Saudis who died on the 19th. Now the story come back again. Number 15, and probably there is a number 14 that are missing in between there. This is a gentleman. This is not number 15. This is a story first, and then we'll go to number 15. This is a gentleman who was diagnosed to have multiple myeloma in an adjacent hospital to us. He was very sick with his multiple myeloma, and he was treated there with the chemotherapy. 2 days later, he had to go to the ICU because of respiratory illness, and he stayed there and he died. His brother, who was working in our hospital as a security guard, during the Aza time, after 4th day, he became very sick and he had respiratory illness, and he was brought to the emergency on Thursday afternoon, 1 o'clock. He was given the maximum support with antibiotics, antiviral, and the mechanical support, respiratory support. We started on ECMO, and unfortunately, by Saturday afternoon, he died. So this is the case of number 15. He's otherwise well. He has no other comorbidity. During the Aza again, so there are 2 brothers who died within 1 week. During the Aza, the 3rd brother, who is Ali, he's 40 years of age, who became sick during the 3rd day, and he became more short of breath, and he was not eligible to our hospital, but we brought him in because there was a thought of the clustering, and we did the specimen for him, and it turned to be that he is positive also with the coronavirus. So this is the 3rd clusters of family that are happening in the same environment. Source, we don't know the source. We'll talk about the source. On the case of 17 is a multiple myeloma with a stem cell transplant, a 73-year-old male from United Arab Emirates who is racing camels. And he has visited the camel who was very sick a few days before. Within 24 hours of visiting that camel who was sick, he got the illness. His doctor in Germany asked him to be medevac to Germany to take care of him, and he managed to treat him. And during one of the samples, it came to be positive for coronavirus. Unfortunately, he died, and the camel survived. So at the end, we have 17 cases, 11 deaths. And this is the timeline of the cases. So since April last year, we have, coming back and forth as a wave. And then the common symptoms that they are presenting is fever, cough, shortness of breath, and breathing difficulty. There are a few milder cases, and the radiological either coming as parenchymal disease, pneumonia, or ARDS. The complication, renal failure, pericarditis, heart failure, DIC, multiple organ failure, and respiratory failure that need to be either on higher doses of ECMO or to be on higher dose of oxygenation with the prone position. The fatality rate is around 64%, and they are usually dying within 4 to 14 days of starting the symptoms, or 2 to 10 days after coming to the hospital. All confirmed cases are adult, male to female. There are some peculiarity about it. It is a male disease for the time being. Still, we are not seeing females. A few of them are females. Occupational are different. 2 of them are healthcare worker, our security guy and the nurse in Al-Zarqa, and one of them is a teacher. Pre-existing medical conditions are few. Animal contact, probably our cases, they have no animal contacts except visiting farms and visiting istirahat, spending the night there. The first case that we had is he had visited istiraha in Al-Amariya, and there it's a valley there that probably there is bats. The other guy, the other clusters is usually living inside Riyadh. One of them is the second one who died. He had istiraha, or a small farm that are below Dirab, which is a small mountain that we had in the south of Riyadh, and he had visited that probably 10 days before. But we think that he got it probably from his brother who died earlier. It could be coming from milder cases. It could be also coming from carriers. Human-to-human transmissions, most family members and healthcare workers closely exposed to these cases are not infected, and we don't know why. If it is still human-to-human transmission or persistent, we would think about spreading the coronavirus. But until now, we did not get this sustained transmission. The route of transmission is as other coronaviruses, droplet and direct contact, and usually from droplets that direct contact coming to the eye or coming to the nose. On 11th of February, there is an interim guidance from WHO on clinical management of severe acute respiratory infections, and when novel coronavirus is suspected, what to do and what not to do. And talk about infection control, and it's still a standard precaution with a droplet precaution and within 1 meter of the cases. And if you're going to do taking specimens with suction or giving high dose of oscillators, ventilators, airborne precaution has to be maintained. The surveillance are for those who are patient with unexpected pneumonias, patient with unexplained, severe, progressive, complicated, and those who are traveling to areas with knowing that they had the disease ongoing, and the clusters of severe acute respiratory infection, and in healthcare worker. The risk assessment for the time being is the risk of any person being infected is extremely low. We do not see the sustained, and we are not seeing the cases that are spreading. We have managed to take more than 300 specimens and tested, not tested, stored, and we have followed these patients who are been coming into contact with our cases, and none, walillah alhamd, got any of the manifestations. The risk of any person traveling to affected areas to be infected is very low, and the risk of human-to-human transmission is still low, and the risk of the virus to evolve to be more transmissible is undetermined, and we are on the look for this kind of transmission. At the end, I hope I present to you some clinical ID cases that look alike, and the most important thing is to have our colleagues safe, and our approach are standardized of when we are investigating, and making sure that we comply with the health authorities of notifying about severe respiratory illnesses, severe infections, rare infections, to make sure that our colleagues are notified, and also all of us respond to the same with the same response to the cases. Thank you very much.